Alrighty, this is chapter 2 from your Bontrager textbook of radiographic positioning and related anatomy. Chapter 2 is on the chest. So in this first lecture video, we're going to look at some of the introduction to chest, some of the anatomy in here, and then finish off with looking at and going through a routine chest x-ray. This all begins on page 72. And typically how this book plays out is they start out with the anatomy of the system or area that you're going to look at, and then they go into describing some of the characteristics of that particular anatomy. They give you some of the do's and some of the don'ts. They go into all the pathologies that are correlated with that anatomy. And then they go into the positioning towards the back of the chapter. They give you pictures, they give you all kinds of references to go by. And at the very end of the chapter, they actually give you some radiographs to critique as far as what's wrong with the picture or what would you correct or how would you correct it. That's pretty much the setup throughout this whole book. So what we'll do is start off. We'll look at some of these pictures and I'll try and reference what page they are on. And the first thing that we look at are the divisions of the chest. Okay, now I will state right out of the gate that anatomy is something that you've already had. You are expected to know your anatomy. It is not an anatomy class. I am simply going through what is absolutely vital for you to become a competent technologist. If you are not strong in your anatomy, I sincerely suggest you get out that book and that information that was given to you while you took anatomy and refresh that, because if you start out behind on your anatomy, it is not going to go well for you, because there isn't enough time to incorporate anatomy into all of this lecture and positioning that is being taught in these classes. So if you know you're weak in anatomy, spend some extra time building that up to help yourself. When we look at some of the divisions of the chest anatomy, they reference that there's a bony thorax to the chest, which is basically your protective framework. Protects your lungs, protects your heart, protects those vital organs in there, your aorta. All of that anatomy is protected by a bony thorax. You have your respiratory system is also in the chest that allows us to take in oxygen and to breathe out carbon dioxide. We look at our lungs and our airways that are in there, some of the primary bronchus, the secondary bronchus, and the tertiary bronchus, the alveoli are in there. And then we also have the mediastinum, which is the space that is actually found between the lungs. Okay. On this picture here, what they have done is labeled each of the ribs, and these are counting posterior ribs. So you've got the first rib right here, and then you've got second rib, third rib, fourth, fifth, sixth, 7, 8, 9, 10. The first 8 are your true ribs, or 7. Now I just blanked out myself, but you have the true ribs and the false ribs. This only goes up to number 11, and then number 12 is obscured by the diaphragm and the abdomen anatomy. But realize that 11 and 12 are considered floating ribs. And the first 7 or 8 true ribs connect to the sternum, and then either 8 through 12 or 9 through 12 are considered false ribs because they don't connect directly to the sternum. All right, when we look at the bony thorax, realize that we have a sternum, which the lay term for that is your breastbone, and the sternum is made up of the manubrium, which is at the top, the body of the sternum, and the xiphoid process of the sternum. We have 2 clavicles, or lay term would be your collarbones. We have 2 scapula, again lay term would be your shoulder blades, and we have 12 pairs of ribs and 12 thoracic vertebrae. Okay, all right. So that takes care of your bony thorax that we look at. Now, in that bony thorax, we have some positioning landmarks that we reference. These are topographic positioning landmarks, meaning a topographic landmark are parts of the body that are easily and consistently located on patients, just like these parts in the bony thorax. So we have several that are listed on this slide, and I have added what level, meaning what vertebral level these areas actually lie. Okay, so let's do the posterior landmarks first. We have the vertebral prominence. All right, and in the book they tell you it's C7 in the beginning, and then they go on to tell you it's really C7 or T1. So this one they're pointing out vertebral prominence is C7, but at times T1 actually sticks out further. So if you were to bend your head down and reach back behind your neck and feel that really bony prominent part that sticks out, that is your vertebral prominence. And that is a good positioning landmark that we use when we do PA chest. We also have, it's not necessarily a landmark, but mid-thorax is at the level of T7. Okay, so T7 means thoracic number 7. C7 is cervical number 7 and thoracic number 1. So in this area is the vertebral prominence. That is a palpable landmark. This is just telling you what's the middle of the thorax. That falls at T7. On the anterior surface, we have the jugular notch. The jugular notch could also be called the manubrial notch, and that is at the level of T2, T3. Okay, so T2, T3. And anytime something says it's at the level of, it's typically describing a vertebral level. So your answer is typically going to be something with the cervical spine, thoracic spine, lumbar spine, or sacral segments. And then the xiphoid process, that is also a palpable landmark. It typically identifies midline, and that sits at the level of T9, T10. So this is a very important picture. I would absolutely make notes of where these lie, what vertebral levels these lie, because these are not only palpable landmarks, these three are palpable, meaning we're going to touch them and find them on a patient. But this also shows us that mid-thorax, that is where your central ray is ideally for all chest x-rays. All chest positioning, you're typically centered to T7, which is at the middle of the thorax. We also have our respiratory system in this chest chapter. And the purpose of the respiratory system is to exchange gaseous substances between the air and the blood. So typically we blow off carbon dioxide and we breathe to gain oxygen and distribute it through the body to the various tissues and organs. And they reference that there's 4 divisions of the respiratory system. We have the pharynx, the trachea, the bronchi, and the lungs. And this is on page 73. With the pharynx, just realize there are 3 parts to the pharynx. You have your nasopharynx, your oropharynx, and your laryngopharynx. Okay, so 3 parts to the pharynx: nasopharynx, oropharynx, and laryngopharynx. And then you have your trachea, which the trachea typically is responsible for taking air down into the bronchi and ultimately into each of the lungs. And then the muscle we use in respirations in the respiratory system is the diaphragm. And you have each half of the diaphragm is considered a hemidiaphragm. So this is the left hemidiaphragm, this is the right hemidiaphragm. Realize that the diaphragm is a dome-shaped muscle, or like an umbrella-shaped muscle that moves down when we inspire or breathe in, and it actually rises when we exhale or expire. So it goes down on inspiration, up on exhalation, and that's how we allow air in by the diaphragm moving down to fill the lungs as full as they can, and then when we blow out, the diaphragm pushes up against the lungs to force the air out. Not all of the air. You typically don't lose all of your air until you are deceased. You know, when they talk about sometimes people talking in the morgue or moaning, that's usually the point at that time, which is usually like a day or two beyond their deceased. The air will actually escape through the vocal cords, and it actually sounds like they're moaning or gurgling, and that's when all the air is actually expelled at that point. When we look at the respiratory system and the trachea, realize that this picture actually comes from page 74. Nope, 75. 75, figure 2.8. Okay, they point out all the different cartilage that's in there. You can see the larynx, you can see the trachea, and how the bronchi start to come in at the bottom of the trachea. But one point I wanted to point out, because it is important, and we've talked about it before with ET tube positioning, this area right here where the trachea bifurcates into two, okay, so where it splits into right and left main stem bronchus, this area right here is called the carina. Okay, and the carina is important because we've talked in the past about ET tube placement is typically placed 1 to 2 inches above the carina, so that when they ventilate the lung, it actually will ventilate both lungs. Okay, so when they put the ET tube in and they start to bag the patient, if it's about 1 to 2 inches above the carina, which is the area of bifurcation, then it will actually inflate both lungs appropriately. Look at the respiratory system bronchi. Now this is, again, this area right here is the carina, but what they're showing you is you're looking at the carina from above. So we've talked about when the ET tube is malpositioned, when they go to put it in, typically it will slide down the right main stem bronchus, because they show you that imagine if you were a tube and you were coming down, it seems easier to slide down in here. To go in here, you almost have to stop and pivot to go to the left. So most malpositioning of an ET tube is that it will slide down the right main stem bronchus. And when they start to bag the patient, only the right lung will get air. And what can happen is the left lung can actually close off and collapse. So it's important not only that we take our x-ray, show that the line placement is correct, but also that respiratory therapists listen to both lungs and make sure that they have bilateral lung sounds when they intubate a patient. Okay. When we look at the secondary bronchi and the alveoli, again, you've got the trachea bifurcates at the carina into the right and left main stem bronchus, and then you end up having secondary bronchi come off that, and then tertiary bronchi, and ultimately it ends at the alveoli. And these alveoli, or these little grape-like structures, that is where gas exchange actually takes place. You trade out carbon dioxide for oxygen, right? And then all that is brought back to the lungs to get reoxygenated and distributed out to the various tissues and organs of the body. So the alveoli, specifically the respiratory membrane that covers the alveoli, that is where gas exchange takes place. And these alveoli are pretty interesting. They're very small. Tom is a respiratory therapist, and he was taught in school that if you were able to take the alveoli out of each lung, in one lung, if you took out the alveoli and laid them side by side, they would cover a tennis court. So if you were able to take the alveoli out of one lung and lay them down side by side, literally cover a tennis court, which tells you not only how small they are, but how many of them there actually are, which is crazy. The book states that there's 500 to 700 million alveoli. crazy. All right, this is an actual image, so like a CT image, like a slice through the body like it's a loaf of bread, looking at the heart and the lungs at the level of T7. So you can see this is representing thoracic level 7. You can see that there are 3 lung, or this is the right lung with the 3 lobes. You have the superior lobe, the middle lobe, and the inferior lobe. And then the left lung only has a superior lobe and an inferior lobe. And in between each lobe, you have a fissure, and that fissure separates that lobe. You can see you've got the heart in there, pulmonary veins, your esophagus sits in there as well, the blood vessels, the aorta, vena cava, all of that sits in there. So this is actually looking at the body like a slice of bread. These right here represent the ribs. These little dashes of white there represent the ribs, and then you can see muscle and bone and skin outlying everything as well. When we look at the lungs, again, the right lung has 3 lobes, superior, middle, and inferior, and the left lung has 2, superior and inferior. And then you've got fissures in between that separate the lobes. When they reference the pleura is what actually lines the wall of the chest and the organ, which is your lungs, and the parietal pleura actually lines the wall, and you have what's called visceral pleura that lines the actual lungs themselves. And the space in between the visceral and parietal pleura is called the pleural cavity. And what happens is that pleura secretes a liquid like a serous fluid, and it allows the visceral and the parietal pleura to glide across each other, basically so that when you breathe in and your lungs expand, they don't stick to the chest wall because you've got that pleural fluid that allows it to just kind of glide along it, and then when you exhale, it comes away from the wall. Now, people that have pleurisy, that actually is what happens. They don't have enough pleural fluid created, and their lungs are actually sticky and tacky, and they stick to the wall. Very, very painful condition to have. Okay, so the pleural cavity lies between the parietal pleura, which lines the wall, and the visceral pleura, which lines the organs. When we look at the pleura in this next slide, typically it is double-walled, meaning it has visceral and parietal. And they reference that some of the chest pathology that you can see in the respiratory system, you could have a pneumothorax, which is the presence of air or gas in the pleural cavity. You could have a hemothorax, which is the presence of blood in the pleural cavity. You could have pleurisy, which is a lack of pleural fluid. You could have pleural effusion, which is excessive pleural fluid, and it actually sits in the pleural cavity. And the older term for that was a hydrothorax, which technically means water on the lungs, but we don't really have water, so it was the pleural fluid. And then last, empyema, which is pus in the pleural cavity. And we've talked about those things before back in patient care, but just realize when the lung or a portion of the lung collapses, you have that space, and when that space gets filled in where the lung was, basically when the lung collapses, you have atelectasis. And then whatever fills that space would give you either a pneumothorax, a hemothorax, pleural effusion, or empyema. Okay, because ideally nothing is supposed to be in the pleural cavity. It's simply just supposed to be space between the parietal and visceral pleura. Now, if we look at some anatomy on page 78, they have both these pictures. This right here would be a PA chest, and this is a left lateral chest. So when we look at this chest, if we look at the PA, B represents the apex of the lungs, which are the top rounded portion, and you have 2 apex. Typically, you refer to those as the apices. 1 would be an apex, 2 would be the apices. So that's what B is representing. A is representing an air-filled trachea. Ideally, when the patient is breathing in and holding their breath, you will see an air-filled trachea in here. Sometimes, depending on the age of the patient, the trachea can actually calcify, and you actually can make out the trachea and actually see the carina. C is pointing to the area of bifurcation in that carina. D is representing the base of the lung. Okay, so you have a base on the left lung and a base on the right lung. And E is representing the diaphragm. And realistically, D and E are very similar. D is just representing the lung portion, so it should be in the black, representing the base. And E represents the white, which is the diaphragm right underneath the base. Okay, so E is the diaphragm, D is the base of the left lung. Remember, again, you have 2 sides to the diaphragm, so this would be the left hemidiaphragm. This would be the right hemidiaphragm, but the entire thing is just the diaphragm. F represents the costophrenic angle, which is the angle that is created between the lung and the rib on the outside. So you have 2. You have costophrenic angle here. You also have a costophrenic angle here. And we have another angle that's a little more difficult to see. It's between the heart and the lung, and that is called the cardiophrenic angle. Those are a little more difficult to evaluate, but typically costophrenic angle, we have to be very, very careful. That is very close to being clipped. So I'm not sure that wouldn't need to be repeated, because it's very hard to make sure that you did not clip any of that lung in that particular picture. All right, G represents the hilum. This is the blood vessels that basically feed the lungs blood. It's called the root region. And this, typically you look for hilar markings on the chest x-ray. So that's actually pretty good. And then if we turn and look at this in the lateral view, which is at the bottom of page 78, again, A is representing the apex. I believe that's what they're representing with that. A represents the apex of the lung. Let's see, on the lateral, same parts as those labeled in the accompanying drawing. Some of the lower lobe, which is D, extends above the level of the hilum, which is C. Posterior portion of the diaphragm is the most inferior portion. And then they show you the oblique fissure. F right here, these are the 2 hemidiaphragms. You can see that one sits higher than the other, and that is because typically the right hemidiaphragm sits higher than the left because of the liver. Okay, so again, A represents the apex lung, B represents the upper lobe, C are the hilar markings or the hilum, E is the base of the lungs, D represents the lower lobe, and F is the 2 portions of the hemidiaphragm. So excuse me, sorry about that. I hope it caught me, but all we were saying is the structures that sit in the mediastinum, trachea, esophagus, thymus gland, and the heart and great vessels sit in between the lungs. I'm not sure when it kicked me out, but that was the last thing, and then I stopped once it started spinning. Okay, now we're going to look at some of the radiographic positioning and technical considerations that we look at when we do a chest x-ray. Okay, first thing we have to consider is the body habitus. And the body habitus, we said, is basically the framework of the patient. Like, we all have the same organs in our body, but how they spread out, whether they spread out wider from side to side or they tend to drop top to bottom, is totally dependent on the framework of your body habitus. Right? The tallest, narrowest body habitus would be an astenic patient. Then we have just above that, we have the hypostenic patient, which means just slightly below normal. They tend to be a little bit taller and narrower side to side. Stenic is an average person, average height, average, and then a hyperstenic person tends to be a little bit shorter in vertical height, but a little bit wider from side to side. Now, why does it play a part in chest x-ray? You can see the purple lungs, and they show you on a hyperstenic patient, they tend to be short and broad. On an astenic patient, they tend to be very long and narrow. Okay, so the patient's body habitus actually determines the orientation of the IR. Are you going to place the image receptor lengthwise or crosswise? And sometimes you'll hear techs say we're going to place it portrait, which is lengthwise, or landscape, which is crosswise. So if you had to draw that, and you had a 14 by 17, this would represent lengthwise. Okay, where it's 14 this way, 17 this way. And if it was crosswise or landscape, it would be placed this way, where this would be 17 and this would be 14. Okay, so lengthwise or portrait, crosswise or landscape. Okay, all right. The body habitus types with regard to what the images would look like. If this patient, I know it's asking you what body habitus, but I can tell you this patient is hyperstenic. Now, how do I know? You can see that the skin line takes up the entire image receptor. It's full, the entire body is filling this whole image receptor. You can see that the lungs tend to be a little bit shorter from top to bottom, and everything spreads out a little wider. So this is a hyperstenic patient, and this is female. You can see the breast shadow right here. Okay, so that is a female patient. So not all hyperstenic patients are males. You can have a hyperstenic male or a hyperstenic female, just like you can have an astenic male or an astenic female. This particular body habitus right here, this is a hypostenic patient, meaning that they are, they're relatively long from top to bottom. You can see that the image receptor, the apex is very close to the top, and the costophrenic angle is very close to the bottom. So taller and narrower. But again, the lungs just appear differently in different bodies. Even the exposure factors, this tends to look a little bit more grayed out compared to this one. Could be an age difference, could be a pathology difference, could just be the tech that took them completely different. I mean, honestly, you can get information off of this. I prefer this look, but I'm also not a radiologist. This is a female as well, because you can see breast shadow right here. Okay, so both female patients, hyperstenic, hypostenic. They do talk about inspiration versus expiration chest, and this is on page 80, right? And they talk about that movements of the thorax during inspiration, when you take in air, and expiration, when you expel air, can change the dimension of the thorax and the thoracic volume. And it says that during inspiration, the thoracic cavity increases in 3 dimensions, and that's this picture over here. Okay. It increases in its vertical diameter, primarily by contracting and moving downward of the diaphragm, so it increases the thoracic volume. The transverse diameter is increased during inspiration because the ribs swing out and up, which increases the diameter from side to side of the thorax. And third, it increases the anterior posterior diameter, which gets increased during inspiration by the raising of the ribs, especially numbers 2 through 6. So when you breathe in, your lung expands in diameter from top to bottom, from side to side, and from front to back. All right. During expiration, the recoil of the lungs, along with the weight of the thoracic wall, causes all 3 diameters of the thorax to return to normal. So you can see this is expansion, not only from top to bottom, from side to side, and from front to back. But when you exhale, everything goes back to its normal dimensions. As far as the degree of inspiration, they do reference that in order to have a sufficient chest x-ray, typically in order to observe how far down the diaphragm has moved, you should count ribs, posterior ribs, in the lung area above the diaphragm. And a good rule of thumb is for a properly inspired chest x-ray, you need a minimum of 10 ribs above the diaphragm. Right? So when we start to count these 10 ribs, you can see they've got, this is number 1, number 2, 3, 4, 5, 6, 7, 8, 9, and 10. Here's the diaphragm down here. So with 10 ribs above the diaphragm, that is an excellent, well-inspired chest. Now, is every patient going to be able to do that? No, probably not. But if they can, that is ideally what we want, is 10 ribs visualized above the diaphragm. When we look at the patient preparation, in order to do a chest x-ray, when we look at how the patient prepares for that, they have to remove all opaque objects from their chest and neck, including any clothing that has buttons or snaps or hooks, zippers, anything that could be visualized as artifact on the radiograph. All right. In order to make sure they remove all of that, typically we ask the patient to remove all their clothing, including their bra, necklace, any other objects around the neck, and then they put a gown on with the opening to the back. So if they have any piercings, you would have to ask them to remove those. Anything that they cannot remove, they probably will let you know. If they have some kind of piercing can't be taken out, or some kind of dermal piercing. If that's the case, you simply have to note on the register, on the requisition, that you asked the patient to remove it, but they could not, or they refused, or they weren't able to, whatever the case may be, just so the radiologist knows that you attempted to do that. Something else, long hair can be visible on chest radiographs, especially if it's wet or if it's braided. If it's weave, it definitely will show on an x-ray. So if that's the case, you want them to take a hair fastener and kind of tie their hair up so that it is not falling below their shoulders. Okay. Any oxygen lines or EKG lines, ECG lines, you have to move those out of the way if possible, so that you can have as little obscure the chest as you possibly can. Okay, and again, they're showing you him with no gown on, but in theory, you would have a gown on this patient. Even though it's a male patient, it still is proper protocol to put a gown on both male and female patients. As far as radiation protection, it is important that patients be protected from scatter radiation. So typically we use shielding if we are able to. So in this particular picture, you can see this right here is the shield. It is placed on his right side because he is facing he's in a left lateral and the tube is right here. So the tube is coming from his right side in through his left side. So that is proper shielding placement. If we look on the PA, you can see that the shield is placed across his back because the x-ray is coming from behind, which is also appropriate. When we provide radiation protection, it's to limit any repeat exposures. We definitely want to collimate on the patient so that we're just beyond the area of interest. And we've talked about the gonadal shielding and how that can actually protect the patient from excess dose. Notice they have a left marker on the board because it is a left lateral chest. And on the PA chest, we'll see if we can see it. Yep, left marker again on the left side of the patient because he is PA. So good job with marker placement on that. As far as our technical factors, realize that when we are doing chest, we are using high kVp. Our range is 110 to 125 kVp because typically with the chest, we want low contrast, long scale, more shades of gray in these images. So we tend to use high kVp and we want low contrast, long scale for this. We usually use a grid because the chest is thicker than 10 centimeters and our operating kVp is definitely above 60. And typically with this, you want to use a higher MA station so you can have shorter exposure time so that you don't run the risk of motion. As far as patient identification, there has to be identifying information on the image receptor for the patient, typically including their name, medical record number, physician that ordered the exam, what you're doing, and it also has to have a correct marker on there. So on this particular image, they do have a left marker, but the problem is that it is not on the correct side of the patient because this is the left side of the patient. Okay, this is the gastric bubble in the stomach. This is the left hemidiaphragm, right sits higher, heart. So that marker should be on this side. So this is not done correctly. That marker placement is incorrect. And this marker placement is non-existent because we can attempt to see something up here, but there's no marker placement on here at all, which is also not going to fly with the radiologist. Both of those would have to be corrected. As far as our breathing instructions, realize that for most of our chest x-rays, the patient is going to take in 2 breaths and then they're going to hold on the second breath. Okay, so typically you tell a patient, take in a breath, blow it out, take in another deep breath, hold it. Now, why did I talk slow like that? Typically when I tell a patient how to breathe, I try to breathe along with them because if I can breathe along with them, then I know they can handle that. But you'll find some techs out there that literally go, taking a breath, blow it out, another breath in, hold it, and then they make the exposure. And when they do that, the patient hasn't even had time to process what they're saying. So a lot of times you won't get 10 ribs above the diaphragm because they didn't give them the time to take in that deep breath. Okay, so you want to use clear, concise instructions. You make the exposure on the second full breath when they hold it, and you have to have 10 posterior ribs above the diaphragm. That is ideal. I mean, if I had 9 and a little bit of space, I probably wouldn't do much. But depending on the patient, if they had no reason why they couldn't do that, I would probably repeat. If they're very short of breath or winded or asthmatic, that would be a good reason why they're not able to take in as deep a breath as we need them to and hold it. They also talk on the bottom of page 82 that we sometimes do an inspiration or expiration chest. Sometimes you do both. Some of the reasons they give you where you might need to do an inspiration and an expiration, meaning you would take one image on full inspiration And then you would take the same image but have them exhale and hold their breath out as best they can. Now, sometimes the reason radiologists want these to compare, you could be looking for atelectasis, which is a collapsed lung. You could be looking for a foreign body. You could be looking for a fixed or paralyzed diaphragm. And you could be looking for a small pneumothorax. So when those are done, they're taken on full inspiration, and then another one taken on full exhalation. Okay. And then they tell you if you count the number of ribs, you would definitely count less ribs in this one because they're exhaling versus this one, which is full inspiration. Now, why do we do chest x-rays erect if at all possible? It allows the diaphragm to move farther down because of gravity. It helps to demonstrate air fluid levels because air rises, fluid falls, and it prevents any engorgement of the pulmonary vessels. So ideally, we truly want to do our chest x-rays erect, and we also want to do them at 72 inches. Okay, a 72-inch SID is important because it'll help decrease the magnification of the heart shadow, which can complicate the diagnosis by leading to them accidentally reporting cardiomegaly. All right, so when we do a PA chest, any chest x-ray truly, we typically try to do it at a 72-inch SID so that the heart gets imaged more true to size. When we look at patients where they're done erect, this patient was done erect. Notice that there is some fluid in this left lung. You can see the way it's flat across, not pointed at all. So there is some fluid in that left lower lung. You can tell how it kind of just looks flat and just like a line. That is not what it normally looks like. And then when you do a supine chest, where they're laying flat on their back, notice that the fluid in the right lung obscures the entire lung because it's spread out more. If they could sit that patient up, it might not look as bad because gravity would help and it would kind of layer out and show you exactly where it is. All right. They talk about some of the evaluation criteria that we have to look at for a PA chest. And one of the first ones that we look at is that you want to make sure that the SC joints are not rotated. So in this particular picture, they're showing you the SC joints is between the sternum and the clavicle. These are sternoclavicular joints, and these are equidistant. There is no rotation. But on this particular picture, where they outline the end of the clavicle in relation to the sternum, there is excessive rotation on this side, which is the right. So the right is pulling away from it, which means that that patient is in an LAO. They're turned more towards their left side. Okay, and that is not what we want. So this one's bad. This one's good. This one, no good. This is no good up here. Okay. That's one thing we look for. We also, they don't give us a picture for every single one of these, but realize that we have to demonstrate both apices above the clavicle. That's another factor that we have to look at, that your apex of each lung, the apices, are above the clavicle. You have to demonstrate both costophrenic angles on that image. Remember I told you that this one's kind of close down here. You could argue that some of it was clipped, whereas this one, you can absolutely see how it comes down to that point and then goes up. So you have to demonstrate bilateral costophrenic angles. The scapula have to be out of the lung fields, which in this they are. You can barely see a little bit right here, but the scapulas are out of the lung fields. What's the next one they give us? They give us that the chin has to be up. Okay, so on this one, the chin is elevated. This one, the chin is down, and it can obscure anatomy, especially over the apices. Right? There has to be lung markings, like there has to be hilar markings in there in order for it to be a diagnostic chest x-ray. You should be able to visualize the thoracic spine through the heart. Okay, that one doesn't do that so well. Let's look at this next one. You can see the spine coming down through there. See how you can see the trachea full of air, and you can kind of see it going into the right mainstem bronchi. We don't really see so much the left, kind of barely right there. Ideally, all of these x-rays should have a proper left marker in the proper position. We've discussed that you need 10 pairs of ribs. And this one says you have to minimize breast shadows. So these are the breast shadows right here. Those look pretty good. Typically what they're referring to is if you had a patient with large pendulous breasts, you would try and move those out of the way as best you possibly could. And when I say you move them out of the way, I mean the patient. You would ask the patient to lift their breasts and separate them to the side so that they could get a little bit closer to the board. All right, we're not going to look at the positioning just yet, but on a lateral chest position, the side of interest goes closest to the IR. 99% of the time, we are doing a left lateral position, meaning his left side is against the board. So this is a left lateral chest x-ray, and notice it's going to be marked with a left marker. Okay, he is shielded, and again, we'll come back to this picture. On the lateral, one of the things that we have to look for is to make sure that there's no rotation. So on this particular image, this image right here, you can see the ribs come right on top of each other, and there is literally no rotation. So in that area, they're right nice on top of one another. I mean, each rib, where they meet in the back, right on top of one another. Okay. On this particular image, though, notice how there's a gap in between. Like you've got one rib here and the other rib here. One here, one here. Anytime you have that big of a gap, if it's more than the width of your pinky, it absolutely should be repeated unless the patient has a medical condition where they cannot get their back straight. So on a lateral, you have to make sure there's less than 1/2 inch of rotation. Okay, less than 1/2 inch of rotation is required on that. Also have to make sure on the lateral that the patient's arms are raised high so that there's nothing obscuring. This patient, their arm down, which allows some of their arm tissue to obscure all that anatomy. Like all of this would be lung tissue, but you're obscuring it because the arms are too low. So they should be nice and up like this. This is actually a bar. Sometimes we have the patient kind of rest their arms on the bar just to help guide them in what they need to do. The central ray on a chest x-ray is always centered to the middle of the lungs, and typically that level is T7. Okay, typically central ray is at T7, and most of the time, if your orientation of your IR is correct and your central ray is correct, then you should be demonstrating the same amount of collimation. Like on this, you should be able to see from here to here, you have the same amount of distance at the bottom as you do at the top. Whereas on this one, you've got a little bit at the top, but you've got all this at the bottom. Why? Because your central ray was too low on here. Center of the lungs is up here. So if you brought it up, you know, that much, you'd probably have to here, and then you'd probably have a little bit more up here. They would be a little bit more equal. You basically want your image to be aesthetically pleasing to the eye, because when you look at this, you tend to focus on the chest. When you look at this, you focus on the chest. When you look at this, I don't know about you, but I tend to focus right down here, and that's not where you want the radiologist eye to be drawn. So you could have collimated a little bit more side to side to get rid of that, and you could have raised that central ray up a little bit so that it was a little bit better centered. When we look at the PA chest, they show us some topographic landmarks that we can use. So if we're going to do a PA chest, we would not use jugular notch, okay, because that's on the anterior side. So we're not looking at jugular notch, but we literally are going to look at vertebral prominence as one, and we can also look at the scapula. The inferior angle of the scapula is another one that we can look at. All right, so this is found on page 86, and they tell you one way you can do it is to use what's called the hand spread method. So for a PA chest, typically on a female, you're 7 inches below vertebral prominence, and on a male, you're 8 inches below vertebral prominence. And what they tell you you can do is to take your hand and spread it out. Spread your thumb and your pinky out and measure whatever yours measures. Like mine measures 7.5. Okay, so if I were to do that and I need 7 for a female, I know that I go a little bit above where my finger ends, about 1/2 inch. And if I need 8 for a guy, I would go a little bit beyond where my finger ends. Okay, that is one way. I'll be honest with you, I used to teach you guys to do it that way, and it takes a little bit longer, and techs were getting annoyed in the field. So what we started to do is to go with you palpate the inferior angle of the scapula. Okay, now the scapula tends to come down, and it has a point. This right here is what you're trying to palpate, the very bottom angle of the scapula. And if you palpate that and make this crosshair, draw this a little better, maybe I can put it right on the line. If you draw that, if this guy's scapula comes down, okay, and you feel that, and you place this line across the inferior angle of the scapula, and you place this line down the middle of the spine, then in theory, here should be T7. And that's where you're supposed to be centered, is T7. Okay, so we're going to palpate the inferior angle of the scapula, because most of the time that does lie at T7. And this is just showing you the hand spread method. Again, 7 inches on a female from vertebral prominence down. On a male from vertebral prominence down, this should be 8 inches. So 7 inches, 8 inches. When they do an AP chest for a topographic landmark, they tend to use the jugular notch, and they go 3 to 4 inches below the jugular notch. All right, and that's for older or hyperstenic patients, they tend to go to 3 inches. An average adult is 3 to 4 below jugular notch. And then if it's a younger person or they're stenic or hypostenic, they're more athletic, you're usually going 4 to 5 inches below jugular notch. So honestly, anytime I do an AP chest, I would tell you that this crosshair typically runs nipple line. And I know sometimes you're not going to be able to see that on the patient, but sometimes you are able to visualize where nipple line is, and you can actually center there. And that's for an AP chest. As far as collimation guidelines, as far as your borders, you want to be above the apex so that you don't clip the apex of the lungs. And you want to be below the costophrenic angles so that you don't clip those as well. Okay, so you can see light field wise, you can see light above the shoulders on this patient. Honestly, this patient looks like something's wrong, only because you can see this shoulder is nice and up here. We look over here, this shoulder kind of drops down, almost like he has a dislocated arm or something. I'm quite sure he doesn't. He might just have it down lower than this one. But if you look at that, it's kind of interesting because this comes down like this, and this one literally comes down, whereas you would think it would come up like this. Kind of crazy. All right, so collimated light just above the apices, light below the costophrenic angles so that you don't clip anything. And these are really excellent. This is excellent costophrenic angles right here and excellent apices. Excellent collimating all the way around. And then you can visualize left marker on the correct side of the patient, which is the left, so that is good also. All right. Again, now we're going to look at the chest x-rays, but I will tell you that if you look on page 88 and 89 and 90, that is where all your pathologies for a chest are listed. They're listed in paragraph form, and then they're also put into a summarized chart on page 89. Those are very important for you to look at. I'm going to give you a handout that you have to fill out with all of those pathologies, only because these are the things that we're trying to look for when we take our images. It's important to recognize, how would pneumonia look on an x-ray? How would emphysema look? What would somebody that has a pneumothorax look like radiographically? So all those can be found on pages 88, 89, and 90. Actually, there's some on 91 as well. And then after that, they go into the positioning, begins on page 92. So for the chest x-rays, in this first PowerPoint, we're just going to look at a routine chest. And then in another one, we will actually look at some of the specialty views. AP supine or semi-erect chest, a lateral decubitus, an AP lordotic, and then the obliques, the anterior and posterior obliques. Okay, so for a routine chest, notice we do a PA, and realistically, this should be a left lateral. So it is a lateral, but it's typically the left lateral chest. So the PA chest can be found on page 92. All right, and realize that the IR can either be lengthwise or crosswise. Remember, we said that lengthwise means that the long axis goes from top to bottom. Crosswise means the long axis is side to side. Okay, I know not the best drawings, but it could either be lengthwise or crosswise. Now with this particular gentleman, I would assume they're doing him lengthwise because he tends to look like his lungs are going to be long, like fill out from top to bottom. He's not very wide. So this, I would argue, they would do lengthwise. Okay. All right. So left marker needs to be on there, and this is the left marker, and that is his left side. The technique on a PHS is 110 kVp at 1.3 mass. Central ray is to T7, which is likely found on this gentleman. We probably found the inferior angle of the scapula and ran this crosshair across there, and this comes down the middle of his spine. So this right here should be T7. He is shielded, which is good, from behind because the tube would be from behind him. And what we're going to have him do is take in a deep breath, blow it all out. One more deep breath in and hold it. Okay. Now, as far as how he's placed, he's standing facing the board. His chin is extended or raised. His hands are on his hips and his shoulders are rolled forward. But when you roll the shoulders, you want to make sure that they don't raise their shoulders. They simply just want to roll them forward. All right, and central ray is at the level of T7. We make the exposure at the end of second full inspiration. And then I just want to point out with this next slide that at the bottom of each of the positioning pages, so this is at the bottom of page 92, they actually give you evaluation criteria that you have to look at. You have to look at what anatomy must be demonstrated in this picture to know if it's acceptable and diagnostic and optimal. So they tell you you need both lungs from apices to costophrenic angles and an air trachea. So do we have both lungs? Yes. From apice to costophrenic angle on both sides? Yes. And do we have an air-filled trachea? Yes. So far we've done that. We need hilar region markings. Yes, we've got those. We need the heart. Yep. Great vessels and bony thorax, meaning can I see the ribs? Can I see the clavicles? Can I see the spine? Yes. So according to the evaluation criteria, they also reference no rotation, where we look for that is at the SC joints. The scapula are out of the lung fields. It is a full inspiration demonstrated by 10 ribs above the diaphragm. Equal collimation at the top and the bottom. No motion, and proper exposure factors, acceptable brightness and contrast on that. So that is a really good image, and we also have our left marker, which is really good. Some other ways that you could do this are on page 93. The patient could be sitting erect to do this. That would be acceptable. The left lateral chest is actually found on page 94. All right, and on page 94 with this image, on this left lateral chest, again, central ray is going to be at the level of T7. So with his PA, we did his PA lengthwise, right? We said that on this particular picture, we did him lengthwise. So when we go to do his lateral, because it was lengthwise, if the PA was done lengthwise, we don't make any adjustment to the central ray. We simply turn him sideways, and our central ray stays exactly where it was, because it's still going to fall in line with the inferior angle of the scapula, and nothing needs to move. Okay, we want to make sure he's not rotated. We bring his arms up above his head. We turn the shield to cover his right side. We make sure the left marker is still on there. We set the control panel at 110 at 3.3. So we go up because he's thicker now side to side than he was front to back. So we need a little bit more to get through. Okay, and then again, double inspiration, and we make that exposure. Now, why do they have this line on here, and why are they showing me the ribs? If you look on page 94, under respiration in note 2, it says that if the patient basically was done crosswise for a PA, then there could be an increase in OID in the lower chest, which can result in the costophrenic angle being projected lower because of the divergence of the beam. So when this patient, if this patient was hyperstenic and we did him crosswise, because of where the costophrenic angle is and the way the beam diverges, the potential is to throw that costophrenic angle off the imagery set. So to compensate for that, we would have to drop the IR and the tube a minimum of 1 inch for the lateral. So I said if your PA was done crosswise, you drop your central ray and your IR minimally 1, sometimes 2 inches for the lateral view. Why? To compensate so that the costophrenic angle does not get cut off your image. Okay, you make sure their back is nice and straight so they're not rotated. And again, 110 kVp at 3.3 mass. As far as evaluation criteria, oh, sorry, this was just to reiterate what I said. If you run crosswise, you lower the central ray about 2.5 centimeters or 1 inch from the PA, because if you don't, the divergence could cause clipping of costophrenic angle. As far as the evaluation criteria we look at, on that page 94, if you look at the bottom, it says that you have to include the entire lung from apices to costophrenic angles and from the sternum anteriorly to the posterior ribs and thorax. You have to make sure there's no rotation, the chin and the arms are elevated, that it's collimated, and there's no motion. So, do we have all of the lungs? Yes. Can we see from sternum to posterior ribs? Yes. We can tell there's no rotation because the posterior ribs are on top of each other. The chin and the arms are elevated sufficiently. We have a marker. The collimation looks good. There's no motion. And this looks like appropriate brightness and contrast. So overall looks very good on there. And then some other ways to do a lateral chest x-ray are actually on page 95. You can do it with the patient seated on the stretcher, just sitting up by the chest board. You could place them in a wheelchair and have a sponge behind to help sit them up. Or you could place them in the stretcher and put sponges behind their back to help sit them up. Any of these views would work as an alternate for a lateral chest if the patient was not able to stand. Okay, and those are the views for a routine chest x-ray, including the introduction portion of this chapter and the anatomy. Make sure you go over that. If you have any questions, please bring that to class and we will make sure that we address it so that there's no confusion. We will look at the second half of this chapter in another recorded lecture. Thank you so much.